Thank you very much for that introduction, Dr. Goldenberg. Ladies and gentlemen, thanks for coming this early for this talk. So that's the view of Mount Taranaki in New Zealand. It's a volcanic single mountain. It always has snow on top, and I encourage you to visit. This was not brought to you by Tourism New Zealand. So we're going to talk about the utility of the MRI. We had a similar talk about 2 weeks back. So because of that, I got some of the technical aspect out of the talk, but happy to answer any questions. I'd like to start with a case, a 57-year-old gentleman who was referred with an elevated PSA. He's been on Proscar for some years now. He's had 4 negative biopsies over the past 5 years for the elevated PSA. Subsequent to that, they were all negative. Subsequent to that, he's had a TURP, which again came back with benign histology. So he's in the clinic because his PSA has risen slightly while he's been on Proscar. And on examination, it's a firm gland, but nothing suspicious. So I'd like you to keep this in mind as we go through the talk. As Dr. Goldenberg briefly mentioned, so the MRI has come a long way over the past 10 years. The technologies have changed. The MRI guided biopsy, the use of fusion techniques, development of using more diffusion weighted imaging, and use of coil, etc., has made the MRI technique quite variable. The reporting has been more standardized. The European Urology put a statement out middle of last year, which encouraging the radiologists to use that PIRAD score to try to make the reporting more standardized across the board and makes it easier for clinicians to use the reporting. And I like to emphasize on that, and I'd like to get back to that a bit later. And obviously, with this topic, I'd like to give you an understanding or make some suggestion on when to consider ordering the MRI. So it's a retrospective review of our MRI series. It goes back as early as 2008. As I mentioned, the technique has changed, so the data is quite heterogeneous, and not every single MRI was exactly the same. We use the keyword MRI prostate and prostate MRI or MRI of the prostate to identify the patients. And we only focused on patients who've been treated in this hospital. Initially, we discovered about 250 patients. After exclusion, after a patient who did not have treatment here, people who did not have subsequent follow-up, people who had the MRI and didn't have the biopsy, we were left with 180. The breakdown comes to majority of being because of the high PSA. Good numbers are patients who are on active surveillance, and then few pre-op planning and abnormal DRE. So we just focus on the first 2 groups, the patient on active surveillance and patient who have had a high PSA. You can see there are rather young group of patients. Goes without explanation, they had elevated PSA, and that would be the reason for diagnosis in the first place. And the patient on the high PSA had, on average, at least 2 negative biopsies. This patient received MRI scan, and as I mentioned, the technique was variable. They all had T2 weighted imaging, diffusion weighted imaging. Some had contrast enhanced imaging. Very, very few had a spectroscopy, and some had endorectal coil and some didn't. So it is quite heterogeneous. So you can see on the table, the MRI discovered some sort of abnormality in over 70% of the patients. And about 43 patients MRI was completely normal. So those patients did not receive any subsequent biopsies. So MRI avoided further biopsies in this group. Based on this finding, and majority of the abnormalities were restricted diffusion. So getting back to our case, so he went ahead and had an MRI scan. We saw an 8 millimeter low signal on T2, and it was showing significant diffusion abnormality. And I'd like to show you the report that, so this is the wording was used. So that's, if you were going to use a standardized report, it would be get a number from 1 to 5, and that way you get an idea how concerned the radiologist was. He went ahead and had a biopsy. He had a cognitive biopsy, meaning they used the MRI imaging, thought where the abnormality was, then they tried to use the ultrasound and try to hit those areas. And he also had a 12-core systemic biopsy. So this is his histology. So he was young, 57. He's got very high risk prostate cancer. He subsequently has had a radical prostatectomy after 6 months of adjuvant hormone and chemotherapy as part of a trial. His margins are negative, and he's only 6 months from the operation, but PSA remains undetectable. But clearly, this is a patient who benefited from the MRI scan and subsequent imaging, as this cancer is lethal, especially with his young age. Getting back to our study, so out of the patients who MRI discovered an abnormality, 66 patients from the high PSA group MRI suggested to have a repeat biopsy and triggered the biopsy, and about 45 patients in the active surveillance. Remember, the active surveillance patients were going to get a biopsy at some point, but MRI was used to target the lesions, if you like, if they were present if there was any abnormality. Obviously, not all of those have been done, so as a result, the numbers won't add up because some patients are still waiting for the biopsy. So that's and from out of those numbers, this is the breakdown. Majority have not had a fusion biopsy, and fusion biopsy, which we speak about a bit later, basically is the newer technology to try to superimpose the abnormality of the MRI with the ultrasound, and this way hopefully improve the detection rate. So how did we do as far as the cancer diagnosis goes? So out of all the patients who had a biopsy in the high elevated PSA group, we discovered 35% of the patients had cancer. The number is, I'll show you the literature, is acceptable, is reasonable. Remember that this is still in the beginning, we're still learning, the technique has been evolving. And in the active surveillance group, we discovered half of the patients we biopsied had cancer. Obviously, it's important to know what sort of cancer we are detecting. So if you look at the patient who had a high PSA, so there were only 18 patients which we diagnosed cancer, I think this is the main point. Over 80% had pattern 4 or 5 in their biopsy. So these patients certainly would benefit from further intervention, considering their other comorbidities. And same goes for active surveillance. And you can see again over 80%, 15 out of 18 patients had a very high grade cancer, including some 4+4 pattern. Now let's look where the MRI detected the abnormality. So you can see transitional zone, which is a place that traditionally the routine systemic biopsies don't sample, had majority of the abnormalities on the MRI. And when we look at our cancer detection, you can see, again, majority of the cancers were detected in that anterior zone. And I think that's a very good use of MRI for targeting biopsy for detecting those guys with cancer. So over 50%. I'll get back to that figure. When we looked at the fusion biopsies, although the numbers are still quite small, we still haven't managed to show that our fusion biopsy was superior to the cognitive biopsy. And when I put it through the chi-square test, the p-value was not significant. But the numbers are small, and as the number gets bigger, I have a feeling that the fusion will show some benefit. Overall cancer detection rate per positive MRI reported was 28%. And I think that's a reflection of reporting and targeting, and we'll discuss that a bit more. So, out of all comers, when they had MRI, how did the management change? So you can see that out of those 18 patients with the high-grade cancer, with cancer diagnosis, which had a high PSA, majority of them end up having some sort of intervention. Majority of them surgical. And in active surveillance, about 11 patients came off the active surveillance because of the finding of MRI and subsequent biopsy. So the pickup rate is low, but let's see how we compare to the literature. And it goes without saying, the single most important factor was the PSA. And the higher the PSA was, the more likely they were going to be positive biopsy, the more likely they were going to have a positive MRI, and the more likely to have a change in management. So perhaps this could be a reminder of when to consider using MRI when the PSA is elevated. So if it's obviously hitting above 10, 15, you are much more likely to detect a positive MRI. So let's look what other people have said. This is a study of 100 patients, very similar to our 96 patients who have had a previous negative biopsy and gone ahead and had MRI scan and subsequent MRI guided biopsy. And that's the breakdown. They had 52 positive and 48 negative, so their detection rate is about 52%. Over 80% of the patients who had positive biopsy had significant cancer, and they're using the Epstein criteria for definition of significant cancer. There isn't much else in it, and as you can see, the transition zone component was quite smaller. It's about 30-something% as compared to our 50%. So perhaps they are not exactly the same group of patients. This is a larger paper just came out from a Dutch center in European Urology. They're using a stronger magnet. They're using a 3 Tesla. Our magnet is 1.5 Tesla. And again, similar cohort of patients, negative biopsy, going ahead and had an MRI. There's a large number of patients. This is a tertiary referral center. Once they excluded few patients, they had 265 patients who, with abnormal MRI, who gone ahead and had an MRI guided biopsy. So big center, big numbers. And you can see, so this is much more similar to our results. The overall detection rate for all patients who had MRI scan was only 25%. Remember, we don't have to find cancers. I mean, patient has an elevated PSA, has had negative biopsies. We've done further investigation. They don't all have to have cancers. And that's what the literature suggests. So 25% of the positive MRI end up being cancer. The prostate cancer detection rate for people who had MRI guided biopsy was 41%. So this is MRI guided biopsy. Our series is combination of cognitive biopsy and fusion biopsy, and we are hitting around 35. So again, very, very similar results. And the proportion of significant cancer remained the same. Another European Urology paper, this is just online. So this is a meta-analysis and systemic review, if you like, of all the published papers, and there were over 80-something they've included. I've just picked this table, and I do apologize, the names of the papers are not there, but the references are available. So let's look. So again, these are mixed groups, all comers. Some are biopsy naive, some have had positive biopsies, so that more likely to be active surveillance group. Some of the papers do not mention anything about the characteristics of the patient, whether they have had biopsy or not. And I like to show you this figure, and this is all cancers detected, that includes systemic biopsies and targeted biopsy. And you can see it ranges from 20 to 60%. If you want to come and look at this column, which is cancer detection per positive MRI, you can, again, quite variable. So 100%, so it's truly reflection of, I think, the reporting. So if they have a very only report what they highly consider cancer, of course we get a much bigger number. If you report most abnormalities, then the numbers would be smaller. And that's what I think helps with the standardization of reporting. Then we can go back and look at all these series, and then we can do a head-to-head comparison. I came across a very important journal, the Vancouver Sun. I just did a search and this came up. So, and this is from 2 years ago, and I think that's probably the start of where we started our fusion technique. So Lindsay McCann and Sylvia Chang in the picture. So just briefly mention about the fusion biopsy. So idea is do an MRI scan, see what the abnormalities are, try to superimpose that with the ultrasound. Sometimes can be done in one setting, sometimes patient has to come back for it, and then try to hit exactly the same areas. I think one of the problems is obviously ultrasound is not as good as the MRI scan. Second of all, you cannot 100% be sure that the area that you think is abnormal has been correctly sampled by the needle. And I think that's where the detection rate can fall. So although the MRI can detect it, if you're not biopsying it correctly, or your needle doesn't reach, or the angle is awkward, so you won't know whether you've sampled it. And then you are in the same situation, elevated PSA, negative biopsy, where to go next? Let's look at some fusion biopsy series. So similar groups of patients to ours. They've used the same technique as ours, combination of cognitive and fusion. And I'll briefly go over the papers. So Vourganti, 195 patients. They used a 3T magnet, so again, stronger magnet. All of the patients had previous negative biopsies. Their cancer detection rate was about 37%. And from those group, about 10% had high grade. Our data was about 30% had high grade, and detection rate was similar. Pinto et al., 101 patients. They used a 3T magnet with coil. So all of them had the same study. Patients group were mixed. A third were biopsy naive, a third were negative biopsies, and a third already had diagnosed cancer. So extremely heterogeneous group of patients. And they diagnosed 50% cancer. No comment about the high grade. Hadaschi, I think Boris was a fellow here, I was told. So they more interesting study, 106 strong magnet, again mixed group of patients. They used the transperineal biopsy and used MRI fusion technique, but the transperineal biopsy, and they took many more cores than what we do normally, and detection rate was higher. I'd like to bring your attention to this statement here. So where the radiologist, where the reporting was strongly suspicious of prostate cancer, out of 24 cases, 23 had prostate cancer on MRI. So that would be a grade 5 on the PIRAT. And I think again, I'd like to emphasize that that's the important thing. If you're getting a strong opinion from your colleague, then you can act on it. Another study saw 171 patients, again strong magnet, mixed group of patients, and the cancer detection was about 50%. And our series are just to the right of that. Although our magnet is smaller, we're not too far off from the figures. Remember, about 20-30 patients still waiting biopsies. Now we're using the fusion technology more often. Experience has improved. I'm sure that number will increase. Let's look at the active surveillance group. Now, this is that not much is available for in the literature. So I think they're mostly Dr. Goldenberg's patient, and I think this is forward thinking. Using the MRI to try to avoid biopsy if it's possible, try to select patients who are going to benefit from a targeted biopsy. I think that's probably one of the better part of my review. So, new paper just came about 2 months ago. We reviewed it in our MRI meeting. 388 patients from Memorial. Because it's spread over a period of 10 years, the technique has changed. So it was initially 1.5 Tesla, then they purchased a 3 Tesla magnet. They're using cognitive and systemic, so it's not done fusion technique. And these patients, these are all active surveillance patients. They all have had one biopsy, so they are more homogeneous. And before they had the confirmatory biopsies, they've gone and had an MRI scan. The paper gets lost in description of how some had targeted biopsies, some had systemic biopsies. And then they comment that 20% of the patient in active surveillance was upgraded after having the MRI scan. And they talk about the negative predictive value and the sensitivity of MRI confirmed to the confirmatory biopsy. And I think that's probably a mistake. Why? Because the confirmatory biopsy could still miss a lesion. So unless you're comparing it to the whole mount, I think it's a bit premature to talk about sensitivity and positive prediction value. Similar study, much smaller. They mostly did cognitive biopsy. They used a coil and a 1.5 Tesla magnet. Similar results. Again, talk about the specificity and sensitivity. I don't agree with that necessarily, and that's why I didn't put it on our series. But again, our numbers, this is the purely active surveillance group. If you look at the cognitive fusion and systemic biopsy, our figures are similar, which probably going to raise over the next few months. Again, we are on par, and there isn't much been published in that group of patients particularly. Let's just talk about other options. So, what if the MRI is not going to detect the cancer? What if where are we going to go next? Saturation biopsy, whether transrectal or transperineal, is an option. Back home, we actually do a lot more saturation biopsy. I requested one of my colleagues to send me his data, and it never arrived. But this is a recent paper. They randomized patients who have had negative biopsies to saturation biopsy, transperineal and transrectal. They obtained about 24 cores. And you can see the detection rate, again, is not much higher. It's about 28%. I like to say they don't all have to have cancer. Some series have 50% cancer. Some have 60%. If there is no cancer, I think that's just that. You can use other tests on PCA3, which is becoming more available. We definitely use it in VGH, and I think you can use that to stratify your patients, and you can reduce the anxiety on your side and on patient side. In someone who had a negative biopsy, normal MRI and a normal PCA3, probably there is a good chance there is no significant cancer. And then there's prostate health index, which I haven't seen in Canada, but definitely available in Australasia, and it's a similar test, uses pro-PSA and use a mathematical formula to give you your risk. So there are other options. So what does future hold? Well, I'd like to see a day that MRI is the only test we order instead of the biopsy. We are nowhere near that yet. There was a controversial move in Australasia where GPs were directly ordering the MRI scan with an elevated PSA and not referring the patient to radiologists. I think that's been managed now. That's clearly wrong. At the end of the day, we are the clinicians and we do have to see the patients. But hopefully that's the future. We already mentioned the use of additional tests for stratification, PCA3, prostate health index. Hopefully they become cheaper and more available. I've mentioned the standardization of reporting multiple times, so I won't go on about that. And hopefully with the MRI, we can do only targeted biopsies. So MRI is abnormal, we see a lesion, we target that, and that's that. By doing that, hopefully we avoid diagnosing the low insignificant cancers. We avoid producing anxiety in the patient and probably avoid over-treatment. And this is now the bottom line. It is coming. There is a technology available in this hospital, and that is when you do a biopsy, the ultrasound will actually mark where your last needle was. So hopefully you can avoid sampling the same area. And I think we're going to see some interesting results from there. Last but not least, let's talk about the cost. I've just done a very, very basic cost management assessment. And so MRI costs about $1,000. Biopsy, this is the 2010 results. From the moment the patient sees the clinician till the pathology comes, that costs about $900. So for all of our high PSA patients, which had MRI and subsequent biopsy, remember there were 96 patients, we diagnosed 18 cancer, 15 of them were significant. We spend about $310,000. And I think that's a lot of money. So it's important to keep that in mind. For active surveillance group, so there were 75. Obviously, they all had at least one biopsy. So I didn't even include that in the cost analysis. They all had MRI. They all, and 64 of them are going to have biopsy or have had biopsy. So it cost about $100,000. And we discovered 11 high-grade, 11 patients who did not want to have active surveillance anymore. So I talked about future. I talked about technology. I'd like to mention how this is going to affect us in the future. So this is a nice study, came last year in Uro-Oncology. It's comparing the cost of treatment across the board. This is only for one of the states, and it's using the Medicare cost. As you can see, in active surveillance at first year is the cheapest, and at 10 years, this is the cumulative cost. If you add 5 MRI scans over the 5-year period, maybe 2-3 fusion biopsies, the cost of active surveillance is going to get up there as well. So technology, costly as well. And it's, again, I just put that on because I think that's interesting. And that's all I'm going to say about that. So what the limitation of my review was obviously is retrospective. The patients were rather heterogeneous. The patient on active surveillance, they had multiple biopsies. Some just this MRI was done just before the confirmatory biopsies. Some had multiple biopsies. Some had a rising PSA. So they are heterogeneous. So we can't really compare them, but it's real practice. The MRI technique was changed during the time, and that's part of the evolution, and can't do much about that. Reporting, talked about that. So the issue is, when you look at the MRI report, and it reads something like this: there is an area in transition zone which is most likely BPH, but cancer cannot be excluded. As clinician, we might biopsy that. The biopsy is going to come back negative. Of course, that's going to affect the results. The results going to be not, show less cancer detection. Again, with the biopsy, if we're not detecting the cancer seen on the MRI scan, that will affect the results as well. So on that, I'll have to leave you with this picture, and thank you for your time. I'm happy to answer any questions.